Hello, everybody. Welcome to our first subject-based conversation with our two favorite Winona doctors. I'm Angela. I work at Winona, and I am here with Dr. Mike Green and Dr. Cat Brown. And today, as you know, since you registered to show up here, we're going to be talking about perimenopause, which is a super important topic. And our doctors have a lot to share with you. In advance of letting them do their introductions, I wanted to kind of share with everybody here that we're going to do things slightly different than our normal setup. Dr. Green and Dr. Cat are going to talk about some various aspects of perimenopause. And it's just the purpose of this is so we can kind of hone in on the things that are really important. And then we are going to have time for Q&A at the last half. So for the first half of this session, the two of them are going to share space and talk about perimenopause. So if you have questions now about perimenopause, start putting them in the chat so that by the time we get to your questions, we can kind of go through them. And I am now going to let Dr. Green and Dr. Cat take it away and make their introductions.
All right. You want to go first, Dr. Green?
Ladies first. Ladies first,
okay. I'm Dr. Cat Brown. I'm an OBGYN board certified. I live in the state of Pennsylvania and take care of patients. So I'm actually on call in the hospital right now. So if I have to suddenly run, that's because an emergency happened and a patient might need my care. But yeah, I'm in my call room, which is kind of a glorified dorm room. And so I have this nice virtual background, but every once in a while we get tech difficulties and the virtual background makes me disappear like an apparition. I'm not quite sure why. But anyway, I take care of patients for Winona in the state of Pennsylvania and also in Florida as well. And soon we'll be taking care of patients in other states as well. But I've dedicated my life to women's health, and I have a particular interest in perimenopause and menopause because I'm kind of going through that point in my life as well. So I'm in this journey with you and experiencing a lot of the same things you are. So that's me. And I'll turn it to Dr. Green. Hopefully I won't disappear again.
I know you're going to be disappearing to run to see a patient, but hopefully you won't have a technical disappearance. So my name is Mike Green. I am also a board certified OBGYN. I actually am double board. I did a family practice residency, and then I found out that I really don't like taking care of sick people. And I love delivering babies, and I was good at surgery, and women's health was a real passion for me. So I did a whole second residency to be able to do this. So I'm really thrilled to be able to really dedicate my career to women's health. I've been doing this for over 23 years, and it's really a joy. And so we started Winona because there's a real shortage of people that are willing or knowledgeable about menopause and willing to prescribe hormone replacement therapy appropriately. And there was even sort of more of a problem to be able to do it in a convenient way. And so we started Winona to be able to do that and to offer hormone replacement therapy in a really scientifically based, excellent manner, but in a super convenient way. So you never have to leave your house except to go to the mailbox. And so this has been quite a successful endeavor, which is great because it means that we're offering something that people want. But one of the things that we feel strongly about is education. There's so much misinformation out there about menopause and perimenopause. And so we want to kind of set the record straight. Everything that we talk about is really evidence-based, backed by good studies. That's kind of, it's really all science-based. So that's what today is for. We're going to talk about perimenopause. We're going to talk about it from our experience as OBGYNs and from Dr. Cat's experience, from personal experience, but everything, science-based. And we do want to answer your questions. So as they come up, please put them in, and at the end, we'll do our best. There'll invariably be a bunch of the similar questions, so we'll probably group them so that we can get to them that way. But that's sort of the ground rules. And Kat, take it away.
Sure. So I guess we should start off really with defining perimenopause. What is it? So basically in a woman's life, we have, as children, we're prepubertal, then we start to get our period, and then we start to get into that reproductive phase of our life where we're having periods every month. Menopause is really when our periods have stopped, but in that journey toward that time frame, there's about a 10-year period where we're in this transition phase. And the average age for menopause in the United States and around the world is 51, 52. And some of us, for women, we can get symptoms of perimenopause for up to 10 years before we actually go through menopause itself. So it's really this transition time in our body where we're transitioning from that time where, our focus of our reproductive organs is reproduction, and now we're changing. And so a lot of things can happen. There's a lot of hormonal changes that happen during this time. As women, we're born with all the eggs we're ever going to have in our ovaries. And every time we have a cycle, as long as we're not suppressing ovulation, we're releasing an egg each month. So that egg number is decreasing. And as that's decreasing, our estrogen levels are decreasing as well. So a lot of times women can start to experience some erratic nature to their cycles. They can start to have symptoms just out of the blue. And some months might be worse than other months. You may start having subtle symptoms of maybe insomnia. That's something I see very often as a first symptom, is that they're just not sleeping as well. You may have in your younger years had a great metabolism where you could eat whatever you wanted, and you could, if you needed to lose a few pounds, you could maybe just make a couple little changes. Suddenly in midlife and in perimenopause, the way that our body holds on to weight changes. Often because of all the hormonal changes and the ups and downs and all the changes in our body, our stress hormone levels are increased, and that kind of forces our bodies to retain weight. And we can retain weight more in our torso and our mid-body, our bellies. A lot of you may have heard the term menobelly. It's very common for women to start to get weight around the midsection around this time. And even though we want to lose weight and we're trying to do everything in our power to lose weight, sometimes our hormones are trying the opposite and trying to retain everything. A lot of the other symptoms I see very, very frequently are the period changes. So your menstrual cycle can have, some changes that can be really bothersome. Sometimes you have no rhyme or reason of when you're going to get your cycle. You may have been previously very regular, getting a period every 30 days, and then suddenly you might skip a month, or you might have 2 in a month, or there's just no time frame that's predictable, and it just becomes more erratic. And that can become really disruptive to our lifestyles, especially, planning vacations and planning intimacy and a lot of things. Vaginal dryness, also loss of lubrication. These are symptoms that we often see starting in that perimenopausal time frame. These are things that we start to see before you actually get the full-blown hot flashes, night sweats. But those will start to creep in perimenopause as well. And it's in this forum, we can't really list every single symptom that you're going to experience because there's hundreds that can happen. The other thing that's very, very common are mood changes, brain fog. A lot of women in midlife will start to feel like all of a sudden they can't focus. They can't keep attention. Maybe they feel like they're getting ADHD for the first time in their life in their mid 40s. And honestly, it's really the changes in hormones that can cause that. And it can mimic many other things that can happen. We can start to see depression, anxiety, the loss of focus and the ADHD type symptoms. But ultimately, they all come down to that loss of estrogen from your body. So these are all things that commonly happen. And unfortunately, these can happen for many, many years until your body actually decides to shut down the factory and the ovaries actually shut down production and you complete menopause. So it's a long period of time. It's a significant portion of our life. And for many of us in midlife, this is when, we're at the pinnacle of our career. We're doing great. Often like we've done all these things in our lives, and all of a sudden we feel like we're falling apart, and it just doesn't feel good at all. And so that's why a lot of patients will seek treatment at this point in their lives in perimenopause. You're both nodding your heads and smiling, but yeah.
I'm like, me, I relate.
Like to have everything together and everything's great, and then all of a sudden things start to fall apart and you wonder, this is not me. You just don't feel like yourself, when all these symptoms start to creep in. So that's the basics of perimenopause. And for every woman, it's different. We tend to follow patterns in our family, but every woman's experience is unique, and every woman's time frame for when perimenopausal symptoms occur or how disruptive they are into their life, it varies from woman to woman, and every woman's experience is a unique one. So That's my spiel. That's how we'll get started with the conversation on perimenopause.
Thank you, Dr. Kat.
Yeah.
Dr. Green, take it away.
All right, so I want to talk a little bit about the hormonal changes and what those hormone changes do, and a little bit more kind of getting into the physiology of this. And so the ovaries are responsible for estrogen, progesterone, and testosterone principally. And the testosterone sometimes surprises people because we think of testosterone as the male hormone, and it is. It's the dominant hormone in males, but there's also some testosterone present in women, and that's also important. Estrogen is really the key hormone. Estrogen receptors are in pretty much every tissue in the body, and so those estrogen levels are really important for driving healthy responses in our tissues, because those tissues all are driven by estrogen. So estrogen has, as Dr. Kat was saying, a huge ramification, and when those estrogen levels drop, can have big changes in how you feel and in your symptoms. Progesterone is also important, but mostly progesterone is important as a balancing hormone for estrogen, and particularly at the endometrium. That's the lining of the uterus. It's the part that sheds when you have a period. And so women that still have a uterus, if all that inside lining of the uterus is seeing is estrogen, it can eventually create a problem because it overgrows. And so progesterone is the hormone that helps organize that lining of the uterus and keeps it from kind of going crazy. And so progesterone is an important balancing hormone to estrogen. And so we generally add progesterone mostly to protect that lining of the uterus. So women that have had hysterectomies that don't have a uterus generally don't require progesterone. Testosterone is the kind of wild card, I think, that like most people don't think about. But testosterone levels on average drop by about 50% from their peak levels in the late 20s, early 30s to like a 50-year-old lady. And that can have a lot of ramifications because testosterone is important for a lot of things. It's important in weight loss, it's important for libido, it's important for energy. So it does have a lot of functioning in the body. The problem is you only need a little amount because that's all that the female body is used to seeing. And it's really easy to push past that and cause testosterone side effects. And so we don't want to do that either. So there's kind of a balancing act there. As the ovaries start to mature, I guess is a nice way to put that, they become less efficient at making these hormones. And there's really kind of two different ways that this happens. They make less and less hormone over time, and eventually they just poop out and stop making hormone completely. Now, that doesn't actually happen the day your period stops. So some people have this idea, we sort of define menopause as 1 year from your last period. Once you've gone a year without a period, you're now, quote, in menopause. But it's kind of an arbitrary assignment, just because we have to use something to put a name on it. But the ovaries are still producing estrogen, progesterone, and testosterone. They're still producing hormone. They're just less and less and less and less. And eventually, they stop producing it altogether. And so that decrease in hormone production causes a lot of changes in the body. Most of those changes aren't desirable. So it can cause hair changes, particularly hair thinning. It can cause skin changes. And it can also it can cause changes in the vagina, particularly thinning of the vaginal tissues, which can lead to painful intercourse. The glands stop working well, so you don't get a lot of discharge. It can also decrease the musculature in the pelvic floor, and that thin tissue and the decreased musculature can cause the bladder, which sits on top of the vagina, to sort of fall. And that can cause urinary incontinence. It can also affect the tissues surrounding the urethra and the bladder. So it can cause urinary issues as well. And that's something that sometimes people forget. And these are all things that happen with dropping hormone levels. But there's another thing that happens that's really more perimenopause specific rather than menopause specific. And that is that it's not just a nice, slow, gradual decrease. The ovaries sort of don't go down without a fight. And so the ovaries are constantly trying to produce hormone. They're just not as good at it. And so they tend to sort of spit out hormone in bursts rather than sort of in nice, smooth amounts. And it's this bursty release of hormone that causes a whole different category of symptoms. And those are symptoms like the night sweats and the hot flashes, those what we call vasomotor symptoms. And those are really caused by this sort of bursting effect as the ovary is still trying to make hormone, but not doing it efficiently. And so it's interesting because that sort of goes away once people are sort of full into menopause. So once the ovaries pretty much shut down, they're not producing any hormone. And so that bursty stuff goes away. So those hot flashes, those night sweats that are absolutely driving you crazy, they do tend to go away once menopause is completed. And so at least there's some light at the end of the tunnel. There are some of these symptoms that get better once it's sort of all over, but those other symptoms that are caused by the decreasing levels, those tend to continue to get worse. So it's kind of an interesting thing. There's also some other really important changes that aren't things that you feel, but are going on in the background. And that is because estrogen is such an important hormone, it's important for cardiovascular health. It's important for the health of your heart and your vascular system. And it's also important for your bone health and your bone strength. And so, for instance, women that have what's called surgical menopause. So we've been talking about sort of natural menopause, but there's something called surgical menopause, and that's when us gynecologists go in and remove your ovaries. And so one day your ovaries are fine and you're producing hormone, and the next day nothing. And that's like really hard on the body. And so women that undergo surgical menopause, they tend to require more hormone for hormone replacement therapy. They have more severe symptoms because it's sort of an instant shutoff. But it's interesting, we know that women that undergo surgical menopause that have their ovaries removed are twice as likely to have heart attacks, heart issues, have heart disease than women that don't. And women that undergo surgical menopause are 85% more likely to have a stroke than women that don't. So we know that estrogen is really important to keeping the heart and the cardiovascular system healthy. And so one of the things that we sometimes forget about is that estrogen is important, not just to make you feel young and better, but it's also important for your basic health and for your longevity. And so we know that women that are, appropriate candidates and start hormone replacement therapy before 60 have a longer life expectancy and a higher quality of life than women that are never on hormone replacement therapy. And it's mostly due to this decreased risk of cardiovascular disease, because that's what most people end up dying from. And so if you have hormone replacement therapy, it's going to keep your heart healthy, it's going to keep your bones healthy. One of the leading causes of death in older women are hip fractures. And some of us have seen this in family members. They're frail, they fractured their hip, they go to the hospital, they get their hip replacement, and then they sort of deteriorate from there, and it's sort of the beginning of the end. And it's unfortunately a fairly common story. And so keeping your bones healthy is really important so that you don't suffer these fractures later in life. And hormone replacement therapy is an important way of doing that. Estrogen is really important for bone health. So there's all these different things physiologically that play a role. And I think it's interesting that there's really sort of these two pathways, this sort of bursty hormone problem and this sort of decreased problem, and they cause kind of different symptoms. So anyway, that's sort of some of the physiology and the science and the ramifications. I'm going to turn it back over to you.
Yeah, so the next thing to really talk about is, how can you navigate these changes? How do you deal with it? What are some lifestyle changes that you can make to kind of help your body to acclimate and to deal with this? So there's a lot of different things that we can do health-wise. Fundamentally, one of the basic things that we can do is just to take care of our bodies. And the way that we need to do that is to really focus on what we're putting in our bodies. Nutrition. Nutrition is really fundamental, and we do a really bad job of educating people on nutrition in America, I think, personally. We all probably remember from school, like drawing the little food group and learning about all this, but then you look at our grocery stores and you look and you see how many of our foods are highly processed, packaged, shelf stable, and able to stay in your cupboard or your pantry for months, if not years, and still look like, the same as when they were produced. It's not good for you, Really, the food that spoils, the food that goes bad, that's fresh, whole foods, those are the healthiest things that you should be reaching for. things that have natural antioxidants, lots of fruits, veggies, berries, lots of whole food diet, basically. Things that are perishable are the healthiest things to eat. And unfortunately, sometimes the healthiest food to get is the most expensive sometimes to buy. So it's, sometimes difficult for everyone to have good access to good produce and good things. The other thing is moving your body. So, really getting into a regular regimen. So we talked about, Dr. Green mentioned about the importance of estrogen to bone health, but also regular weight-bearing exercise and movement is so important for us to get into the habit of, so that we can maintain flexibility, but also maintain bone strength just from the practice of actually moving our bodies and putting stress on our bones to keep them strong. So that's a really important thing to do. Also, if you're starting to experience those vasomotor symptoms, like Dr. Green mentioned with the pulsatile fashion of these hormones, sometimes if you are someone who really enjoys having several glasses of wine with your dinner, those can actually make your hot flashes much worse. So that's something that you might have to modify your lifestyle a little bit, and reducing your alcohol intake, gone are the days that you could party all night and feel great the next day. Midlife is going to change that for sure. I mean, many of us, adulthood and, just maturing has changed that. But the way that alcohol affects you can definitely exacerbate or worsen your hot flashes and your night sweats. Often too, we place so much importance on productivity, and there's this glorification of being busy in the United States. And one of the things that we do is we sacrifice sleep for the sake of being more productive and doing more and getting more done. Yeah, we're all guilty of that, right?
Yeah.
I don't know how many times I've told other people I just wish there were more hours in the day. But one of the things I've learned in midlife is that there's so much more value into dialing it back, slowing down, and really prioritizing sleep. I feel like a hypocrite saying that because as an OBGYN, my sleep schedule sucks. Like right now, I'm in the hospital for 24 hours and I will be up much of the night, delivering babies, answering emergency room calls. And then tomorrow I will be a zombie and I will be trying to nap when I can to try to catch up, but you never truly catch up. So we're so addicted to screens. We're so addicted to trying to fit too many things in, but you really need to focus on optimizing your wellness and your sleep. And for women, and all the women that are listening, one of the biggest things we're guilty of is taking care of everybody else in our lives and not taking care of ourselves. So that's another big lifestyle change. Like, I'm giving you permission right now. Start being selfish. Start putting yourself first. Think about getting on the airplane where they always tell you that put your own oxygen mask on first. You can't be the best person you could be in your job or for your family or in your relationships with people if you're not taking care of yourself and trying to be the best version of yourself that you can be. So this is the time, if you've never done it before, put everything else aside and start prioritizing yourself and really focus on you and your wellness and these lifestyle changes that can help you through this time. And, we can help you with some of the medication sides of things, but you need to put the work into really taking care of your body and taking care of yourself. It's multifactorial. Many different things affect how well we feel and our health overall. But we as patients and people have to take care of ourselves first. So that's one of the biggest things. So the balanced diet, incorporating exercise, managing your stress, optimizing sleep, a lot of homework that you have to start working on. And you'll see a lot of people out there in the media recommending this supplement and that supplement. And yes, there are some things out there that might be beneficial, but the real core comes down to nutrition and exercise and good sleep. And if you can really master those, you'll make a huge difference in how you feel day to day. And I have to listen to that more as I'm telling you this, like I have to practice what I'm preaching. But it's a constant struggle for all of us. And nobody's perfect, and it's all a work in progress. And I can confess right now, this is something I struggle with on the regular. So, it's something we all have to work toward to improve. So on that note, I have to go run and check a patient. So I'm going to turn it back over to Dr. Green, who's going to start talking about some treatment options potentially. So I'm going to take myself off camera and I'll be back as soon as I can.
Okay. Good luck.
She's got to heal the sick. That's a worthy thing to do, I think.
Dr. Kat, aka Mother Teresa. Here we go.
So let's talk about treatment. Basically, the way to fix your hormones decreasing is to give you back the hormones that are decreasing. And so it's not rocket science, really. And so generally, we're talking about estrogen replacement primarily because, again, that's where the money is. That's the hormone that's most responsible for these changes. Progesterone, as I talked about, is an important addition if you still have your uterus, mostly as a protective benefit. There is some benefit to progesterone by itself, but honestly, it's really the protection of the uterus that it's primarily used for. A teeny bit of testosterone, not too much. Unless you're prepping for a bodybuilding competition, knock yourself out. But in general, you don't want to overdo it with the testosterone, but a little bit of testosterone is helpful. At Winona, we use DHEA to get you testosterone, which is a supplement that gets broken down into your body into estrogen and testosterone. It's a nice way to do it because at reasonable doses, 25 to 50 milligrams, it's pretty hard to overshoot and really cause problems. And so it's enough to kind of get you to normal levels, but it's not so much that it's going to kick you into a trouble situation. And so it's kind of a polite way of doing it, so to speak. But estrogen really can come in a variety of ways. So there's the pills, there's patches, and there's cream. That's what we supply. There are pellets that are being used today. And so there's sort of this pellet therapy that has become somewhat popular. Most of the pellets are testosterone based. And again, I've seen a lot of patients that end up getting too much testosterone with the pellets. They're kind of painful. It's basically a big needle and they insert these pellets under your skin and you have to do this every 4 to 5 months. So it's an invasive procedure. I'm not a big fan of pellet therapy. It can work if it's done right. It's a little tricky. It's very easy to do it wrong. And if someone puts in too much, now you're stuck with this until they dissolve. You can't really get rid of it. I don't see there's any advantage to it over the other more traditional ways of providing HRT. In my opinion, the number one reason for using pellets is it makes the obstetrician a lot of money. That's not really a great reason to use something. So like in my office, I don't use pellets. I just think there's better ways of doing it. And, trying to make my next car payment isn't a good reason to do your therapy. So unfortunately, not everybody agrees with that. I can't tell you over my career how many women have wanted a hysterectomy for no particular reason. And it's like, you don't need a hysterectomy. And like, I think surgery is a big deal and I won't perform surgery unless I think it's absolutely necessary. And for some women that really want it, I say, look, the only reason to do your hysterectomy is to make my next car payment. And if you really want a hysterectomy that badly, there are people in town that will do it so they can make more money. I'm not one of those people, but if you shop around, you get your hysterectomy. So, and to me, it's kind of the same thing with pellet therapy. So I'm not a big fan of it. But those are basically the ways of getting the hormones into your body. You can swallow them or you can get it through your skin, either with a patch or a cream, are really kind of the ways to do it. There's another way of getting estrogen to your tissues, and that is vaginal estrogen. Vaginal estrogen works great for those vaginal symptoms and the bladder symptoms because it works really locally at those tissues, targets those tissues, and works quickly, and it's really very effective therapy. It doesn't do much for the rest of your body because it doesn't really get absorbed enough to get your blood levels high enough. So it's not going to generally fix your hot flashes and your night sweats and your brain fog and your metabolic effects that give you the menobelly and those kind of things. But it's dynamite for the vaginal symptoms. So we do sometimes add that to the other treatment options if the vaginal symptoms are really a problem. And it can be a nice way, a nice addition. So those are the sort of therapies that are available. So how do you get these therapies? And it's really important to seek out, number one, a true menopause expert, a healthcare professional. Unfortunately, it's one of these things where everybody's an expert, or at least a stated expert, particularly on the internet. It's funny because I always thought, and I still think this, obstetrics pregnancy probably has more wives' tales and myths associated with it than any other aspect of medicine. I mean, it's crazy how many wives' tales there are about pregnancy. In fact, I gave a lecture a few years back at the hospital, a community lecture called Myth Busting Pregnancy. And I went through I spent an hour going through myth after myth after myth, and I didn't even touch on all of them. And then the science that says why this is true or not true. But there's a lot of myths about menopause and about how to cure menopause and perimenopause. And unfortunately, with the internet, the information superhighway, right? Everything is available, but not everything is good. And there's a lot of junk out there, unfortunately. So anyone can make a website that looks authoritative and good. And even some of the ones that we associate with, wow, this is, a medical website, has some bad information on it. And so you really want to seek out the advice of somebody that really knows what they're doing and does a lot of this. Not just somebody that, I learned about it in medical school. That's kind of not really who you want. Or particularly, your neighbor, well, I went through this and, I drank this tea with this stuff in it and, not really science. So there is a lot of science for this, and it's important. Everyone has to choose how they want to do things in their lives. But for me, I think a science approach and, what do the studies say? And they give people this, they compare it to people that get a fake this, a placebo, and who does better. And those are the kind of studies that I think are important to make sure that what you're doing is safe and actually works, so you're not wasting your time. Unfortunately, a lot of the doctors in practice, especially the ones that are younger than me, didn't really get any education in residency on menopause and perimenopause treatment. And the reason is there was a kind of a big period of time starting in 2002 where everybody sort of turned their back on hormone replacement therapy. They got scared of it based on a study called the Women's Health Initiative study, which ultimately was interpreted wrong. And the problem is the media got their hands on this before the scientists got to explain it, and it created a panic. And that panic is still happening. And so what happened in residency for a lot of people, residency is where we really get our training, is that when they wanted to know about, how do I do hormone replacement therapy? The attendings were like, well, you're never going to do this because it's out of fashion now and nobody wants this. So don't waste your time learning this. And so there's sort of this whole generation of doctors that don't really know how to do this well. And it's a big problem. I can tell you in California, and actually they're more than California, but the biggest health provider in California is, well, besides the government, is Kaiser Permanente. And they pretty much as a rule don't do hormone replacement therapy. And if you really push and shove, you can get some, but the docs there don't do it. And so we have a lot of patients, a lot of Winona patients from Kaiser because they just can't get it from their doctor. And so it's important to seek out good help and advice from people that, this is what they do. And so, this is one avenue. There's other places as well. We're not the only show in town. I think we do it really well, but certainly at least go somewhere where this is what they do. And the other thing is you want to kind of be wary of people that seem to be racking up the bill. I mean, I hate to say this, but it's the way it is. And so I'm a straight shooter. There are people out there that just rack up your medical bill to make money. It's a shame, but it happens. So if you find all of a sudden somebody's ordering $1,000 worth of tests and they're bringing you in every week or 2 weeks and they're charging you for that and they're doing all this kind of weird stuff, it's probably not necessary. And it's somebody that's just sort of racking up the bill. And they may have internalized this, and at this point they actually believe it internally, but it's just the science isn't there. There's really no reason to do all that kind of stuff. It's actually fairly simple. You need estrogen, you need progesterone if you have a uterus, and you need a little bit of testosterone. And it's not that complicated, quite honestly. Everyone wants to make things more complicated than they are. And that's the other thing. There's something called medical theater. So I borrowed this from the TSA, where they call it, I just lost the word. But, I think we all kind of have an idea now that, when we go to the airport and they do all this crazy stuff, it's to make us feel secure rather than actually to be secure. And so there's a lot of that in medicine, and I call medical theater. People wave a stethoscope at you and, listen to your stuff, even though there's no reason to do that necessarily, because it's what people expect. And so people do this medical theater to make it look like they're doing this great stuff when it's really kind of meaningless. And I personally have never really played that game. Again, I'm a straight shooter. It's like, this is what we need to do. This is why we don't need to order this, because it's not going to help. We don't need to do, all these crazy tests because they're not going to change anything. Keep it simple, do it right. That's kind of been my philosophy. I'm cheating over looking at my other screen to make sure I cover everything, because I kind of went down some rabbit holes, but I think I got the section I was supposed to hit. Now I'm looking at what Dr. Kat was supposed to talk about next. And
I think it was just on empowerment, like how we can educate and open conversations about perimenopause.
So educate yourself by going to good sources of information. We have a blog section with I don't know how many articles, a ton of articles that are all peer-reviewed, and we have science-based references of the articles that they're based on. So again, very, we try to, even though it's science-based, we try to, you don't have to be a PhD to understand this stuff, but that's where it's all coming from. So that's a great source. We have a YouTube channel. We got all kinds of all the social media stuff where we have information. There are other good sources too. There's some great blogs and there's some podcasts out there. There's some true experts that also have information. So seek out information, educate yourself. Nothing better than a well-educated patient. You've got to be your own advocate. And that's true for this and really, anything in life, really. Because unfortunately, otherwise you get ripped off. It's true pretty much of anything. It's like trying to understand something about what the mechanic's doing to your car helps to make sure you're getting what needs to be done, that kind of stuff. And it's the same thing with healthcare, and particularly when it comes to the treatment of perimenopause. See something, say something. If you've got a friend that's suffering, talk to them, because they may not understand, and you can do a good deed and help them feel better. So I think that's a pretty worthwhile thing as well. I think I got what she was supposed to hit. All right.
We can start answering some questions.
Let's take questions.
Okay. So I kind of tried to put some of these together. So everybody in the chat, if you don't hear us call out your question specifically to you, know that we're answering it as best we can based on the topic or the type of question you're asking. So we had a couple questions about perimenopause treatment. Is it the same for women in 30s and 40s, or is it altered, the treatment, in terms of from one age to another?
Great question. And the answer is yes and no. So it's not really an age-based thing, it's an individual thing. It's really interesting how different each woman's experience is and the treatment needed as far as dosage for each individual. And so really treatment is symptom-based. So we look at your symptoms. There are some other things that go into sort of our initial guess, so to speak. And so the way it works is, the doctor is going to interview you. We're going to get your history. We're going to find out what your symptoms are, what are the medications you're on, that kind of thing. And then based on all that, we take a best guess of what's going to work for you. And that's what we do at Winona. That's what every doctor does. That's how we do with pretty much every medication. And we take our best guess. And most of us, I know this is my philosophy, I always err on the side of underdosing a little bit because I'd much rather it's like, okay, well, we got you somewhat better, but we didn't quite get there. Let's use this dose a little bit and get you to where you need to be, then overshoot. And now, oh gosh, I've caused all these side effects and you feel worse than when we started. So that's kind of what we want to try and stay away from. So I always kind of take my best guess, undershoot a little bit so as not to accidentally overshoot. And then you take the medication for a certain amount of time, give it enough time to work, because this stuff doesn't work instantly. it takes time. And so you give it enough time to really see, and then you say, okay, where are we? It's like, okay, you hit it right on, great. Or, gee, we didn't quite get enough, we need to adjust the dose. Or, we overshot, that doesn't happen very often. Thankfully, we need to back off a little bit. And so that's the process. And so it's really going to be dependent on your individual body and the needs of your body. And it's not really necessarily age-based. It really is symptom-based and, again, individualized. So a 35-year-old might need more hormone than a 55-year-old, or less hormone than a 55-year-old, depending on what the symptoms and what her unique situation is. So, but it's interesting. 15% of women complete menopause by the age of 45. That's 1 out of 6. That's like not an insignificant number. And since symptoms can start 10 years before that, it's not unusual to be in your 30s, in the second half of your 30s, and start feeling these symptoms of the menopause transition. And it's something that's often sort of ignored or blown off or poo-pooed by people that don't really understand and have enough experience with this. But it's not uncommon that's a point where it may be prudent to start hormone replacement therapy.
Okay. We have a couple questions around recommendations when it comes to HRT and starting and stopping. Some people have questions about, is it common to go like 4 weeks on and then take a week off and then start again? Or are you keeping the dosage, the HRT dosages the same, or are you escalating the dose to keep symptoms at bay longer?
Great. So let's talk about that. So 10, 15 years ago, there was sort of this movement to use what's called cyclic progesterone. So it used to be that everybody sort of gave estrogen and progesterone every day, and that's the way it was done, and it seemed to work well. And then there was this sort of movement that came out. Let's see if we can decrease the amount of progesterone we give by only giving it, say, 14 days out of the month, or 10 days out of the month, or once every 3 months. And they had these different approaches to do this sort of cyclical progesterone. And I mean, it worked okay, but then, there were studies on that, and the data has come out pretty clearly that there's no advantage, probably doesn't work quite as well, and there's definitely more side effects doing it that way. And finally, it's more complicated, and so it makes it harder for the patient to do it correctly. And so then that causes even more problems. And so the consensus now is that back to where it was before that pendulum, is that actually a constant daily dose of hormone replacement therapy is really the best way to do it. It gives you the best results with the fewest side effects. And coincidentally, it's the easiest way to do it because it's a lot easier to remember, okay, every day I got to take these 2 pills, I put in my little pill box or whatever, then, oh gosh, is this the first half of the cycle or the second half of the cycle, or what am I doing today? And it makes it complicated and easy to kind of mess up. And so giving the same dose of hormone every day, no matter what's going on with your cycle, is really the best way to do hormone replacement therapy. The other confusion is that birth control pills are often done cyclically. And the reason is that birth control pills are going after a completely different thing. So for birth control pills, we're completely taking over your hormones. So the idea of a birth control pill is it gives you so much hormone that your ovary just stops producing anything, and so it stops making eggs. And since it's not making eggs, you don't get pregnant. And that's really how birth control pills work. With hormone replacement therapy, that's not really what we're doing. What we're doing is we're coming alongside the ovary and saying the ovary's contributing this much, but it's not enough anymore. And so we're going to add back what the ovary used to make. And so you're back to your normal youthful hormone levels. And so you need that every day because the ovary isn't producing as much as it should every day. So it's really a different strategy than birth control pills because we're looking for a different outcome and we're really trying to solve a different problem. So the way to dose hormone replacement therapy for the vast majority of people is to use it every day. There are rare occasions where I will use the progesterone cyclically, but those are really outliers, And again, there's never just one recipe. So that, there are reasons to do it that way, but for the vast majority of people, taking the same dose every day is the right way to do it. And then the other part is, what about escalating the dose or decreasing the dose? And again, that's symptom-based. So people ask me, what's the right dose of hormone replacement therapy? The right dose is the dose that takes care of your symptoms without causing side effects. That's the goal. And if we're doing those 2 things, we got it nailed, and there's no point messing with that. But what can happen is that over time, your needs of your body can change. And so you may find that you've been on the steady dose for some amount of time, and then all of a sudden your symptoms are starting to creep back in. It's time to increase your dose to get those symptoms under control. Or maybe you're finding that you've been on a nice steady dose, everything's been great, and then all of a sudden you're starting to develop these side effects that are a signal that you're getting too much hormone. It's time to back off a little bit. And sometimes it's up and down throughout this whole transition period. And so again, that's why we check in with people, see how you're doing. We're available if there's questions, and we've got to be sort of fluid and listen to your body. Your body is, very sensitive, and if you listen to it, it'll pretty much tell me what to do for you. And so to me, that's the best way to manage this, is to listen to your body and try and get you in that sweet spot where we've got your symptoms controlled, but we're not causing side effects. And that's what we're going for.
Okay, we have a couple questions for you, Dr. Green, about our favorite topic, weight gain. And every woman here's favorite topic, weight gain. So sort of a two-pronged question. The first question is, someone's asking about why you even gain weight when you start perimenopause, especially if you go on HRT. Like a lot of folks say, I lose weight after, XYZ weeks, months from the water weight, but there's this fear of like, well, if I started, is that going to happen to me? So if you could talk to that a little bit.
So because the hormones, as I said, particularly estrogen and even the testosterone, is very active throughout the body. And so as those levels start changing, it starts changing the metabolism and the way the body functions. And so fat deposition gets changed, and the fat can go into your middle, what's called visceral fat, or your abdominal area, that sort of menobelly, where it didn't used to be that way before. It used to be, hey, when I gain weight, it went to my hips and my chest, and now it's going to my tummy. And it has to do with the metabolic changes because these hormones are very active in that process. It also can decrease the metabolic rate, the metabolism. So, people glibly say, weight loss is calories in, calories out. Well, yeah, okay, that's true, but it's much more complicated than that, particularly the calories out, because calories out has to do with how efficiently your body is burning calories and how it's and what it's using to burn calories and where it's pulling those calories from. When you're not having enough calories, is it pulling the calories from your fat? Is it pulling the calories from your muscle? Where is it getting it from? And so it's not that simple. Ultimately, okay, yeah, calories in, calories out, but that calories out is pretty complicated. And that's one of the things that we're changing is really kind of metabolic rate, and also kind of almost even more important, where the calories are being pulled from. And that's where the hormones can change that. As far as the weight gain with hormones, so there's really two aspects to that. The first is water weight. So one of the common side effects that some people get, not everybody, in fact, probably the minority of patients, but a pretty big minority, is some water retention, particularly at the beginning of treatment. And that water retention, it sucks, really. You're bloated, shoes aren't fitting well, you're uncomfortable in your clothes, the scale is saying scary things and calling you names in the morning. And nobody likes that. I don't like that. And, mine isn't a menopause problem, but, when I eat poorly and I, eat too much salt and whatnot, and I retain a bunch of water, I don't like the way I feel for the next couple of days till I get that water off. That's sort of an initiation part, and that typically goes away with time. For some people, when it happens, it goes away in a week or two. Some people lingers on, can be a month or two. It can be frustrating. There's some outliers there that it happens a longer time, but eventually that water weight will come off. And so it's a scary thing when you start and all of a sudden, oh my gosh, I'm 3 weeks into this and I'm 8 pounds up. And that's a terrible thing. But look, you gain 8 pounds in a couple of weeks, that's water weight. There's just no other way to do that. I don't care how many buffets you're going to. And that water weight will come off. So it doesn't feel good. It doesn't look good. It's not good for our psyche, but it does come off. And so that's kind of most of that weight gain. Progesterone in particular can cause an increased appetite. And the different progesterone, progesterone by definition is a bioidentical progesterone. So the progesterone that your body makes is called progesterone. Synthetic progesterones we call progestins. And some of these progestins are really notorious for causing weight gain. In fact, there's one called Megace that we use for anorexics to help them gain weight because it makes them eat. Provera, which is a very common synthetic progestin that's used in HRT, is notorious for causing weight gain. And the biggest one that's obvious about this, there's something called Depo-Provera, which is a birth control where it's a shot. And it's you see these women come in, 3-6 months in, and they're 50 pounds up. Like, oh, and Provera can do that. It can really stimulate the appetite. And so that is something that can happen with HRT because of the Provera, if that's what you're getting, or other progestin. So it can stimulate your appetite, and that can make you gain weight. The micronized progesterone, which is the bioidentical progesterone that we use, is much less likely to do that. And so that's one of the nice things. Doesn't mean it's zero chance, and there are some people that do get that appetite stimulation with micronized progesterone, but it tends to be a whole lot less than people get from Provera or the other synthetic progestins. So that's sort of one part of it. The other thing is that adding DHEA, which increases testosterone, helps to counterbalance that, and it helps metabolic effects to lose weight. Welcome back, but it also helps the appetite suppressant. So those are the weight gain issues. Most people, if they stick with it, and the weight loss can take a while, will find that the balance is moving the other way. And okay, they were gaining weight, and then now they're not gaining weight anymore, and then they start to lose weight. So I have people at the 3-month mark upset because they haven't lost any weight. I'm like, but have you gained any weight? Because you came on and said, geez, I gained 40 pounds this last year. It's like, yeah, well, you haven't, we stopped the weight gain. Now just be patient, and that we're tipping the balance over and starting into weight loss. And so that's kind of what you can expect. But it's a process for most people, and it takes a long time. The unfortunate thing with most medications, and particularly with HRT, is that side effects don't happen right away, and the benefits take a long time to manifest. And so it's frustrating. But the good news about that is that those side effects happen right away and then burn themselves out, and they go away, and then you get the benefits. So you have to be patient through the beginning process. I think we beat that one to death. So.
We covered the weight gain question. Hopefully that answers everybody's questions about weight gain in one way or another. Okay, Dr. Kat, maybe you want to take this. So we have a very specific question, so I'm just going to ask it. It doesn't really fall into any category where there were other questions like it. So this question is wanting to know if we could talk about the data that demonstrates the combined cream by Winona, that is, if it's sufficiently absorbed to protect the uterus.
Yeah, so I mean, really, there's not a lot of, great data out there comparing topical progesterones to oral progesterones, because most of the progesterone creams that are out there that a lot of patients are buying are over-the-counter, not pharmaceutical grade progesterones. So really, we have been using it, and we trust our pharmacists based on what strength of progesterone they're putting in the cream, and just on our experience with our own patients. Dr. Green and I have kind of gone back and forth and bounced off the idea of maybe starting our own research study so that we can start providing some of the literature out there, because we feel fairly confident that the amount of progesterone in our body cream is protecting our patients very well. And so that's something, and the important thing to talk about when it comes to that is the difference between some of the progestins that are offered out there versus micronized progesterone, which is in our body cream, which is absorbed a little bit better than some of the other progestins that are available. So we feel confident that it's protecting the uterus. And there's more and more data coming out that is going to help to support that. And so I think that more information to come. I disappeared again. I'm watching myself. I see the three of us on the screen, and all of a sudden I just disappear. So I have to click off my camera and then click back on, and then I will reappear magically. There we go. Yeah. Sorry about that. I know that's probably a little confusing when I disappear like that.
It's kind of fun, at least. You keep it lively over here.
I just think that'd be a great trick at a bank.
Right.
I didn't say that. Can I just say there are actually some studies out there that show that look at tissue levels of progesterone at the endometrial level, which is where you need it to protect the uterus, in creams with micronized progesterone with appropriate doses like we use, and there was adequate progesterone in those tissues, which is really what's important. But yeah, there's some, unfortunately, it's confusing out there as to what's really progesterone cream and what's not, because there's all kinds of stuff that's sold that's labeled as progesterone cream that doesn't have enough progesterone to protect you. And so it's something that we're extremely careful about, because safety is our number one priority.
Yeah, I've had patients recently tell me, different creams that they're taking, and I've never heard of them. So I go and look them up, and I go all over their website, and I can't find anywhere where they document what the concentration or the strength of the progesterone is that's in it. And so whenever I see that, it's a red flag to me, because if they can't tell me the dose, I don't really know if what they're promising is in it is actually in it. So that's something very important, to think about. Like when you can buy something over the counter, you have to wonder what it actually is that you're buying. So,
Angela,
hi, I'm here. I'm really trying to disappear. I have a cat who's looking suspicious over on my couch. My elderly cat has decided she might not be with us much longer. So I don't mean like in this hour, but she's just falling apart. So I'm like, I saw her kind of trying to like navigate getting off the couch, and I thought like, oh no, she's gonna hit the floor, and she's not so mobile. Anyways, sorry to interrupt. The question I want to share with both of you, whoever wants to take it, is on the potential long-term side effects of HRT and whether or not you need to up your dose of HRT as you enter from perimenopause into menopause.
Well, so the changing of doses, I'll tackle that one. So, when you first start having symptoms in perimenopause, your ovaries may still be producing some of their own inherent hormones. And so the dose that you need when you're first kind of starting this journey may totally change as, the ovaries start to decrease the production of the estrogen overall. As your body's own production decreases, the dose that you need to maintain your symptom relief may need to increase. Every patient's a little different when it comes to that. But, as we age and as time goes on, we may need to make adjustments in response to what your body's doing itself. So that definitely can happen. And as far as long-term, side effects or risks, when we think about hormones, a lot of times you'll read, about the risk of clots, the risk of, DVT or PE, which is a blood clot in the leg or the lungs. People worry about stroke risk. And when you think about hormone therapy in relation to other medications that can also increase that risk, we like to compare it to birth control hormones. Many of us take birth control hormones, especially the pill, patch, ring, at varying points of our reproductive life. Those doses of those hormones and their synthetic hormones are much higher. The risk of those things and the clotting events is much higher with birth control hormones than it is with hormone therapy. So although it is a risk, we in the OBGYN community don't see it as often as compared to patients on birth control. The frequency of those complications is much higher in younger women taking birth control dosages. I don't know if you want to add to that, Dr. Green.
Yeah, it's actually an interesting finding. When they parsed out the Women's Health Initiative study, what they found was that the increased risk of cardiovascular events, heart attack, stroke, the scary stuff, really was just the first 2 years. And then after that, the risk actually decreased, not like decreased over what it was, but actually you had women that were on it had a lower risk than women that weren't on it. And so estrogen is cardioprotective, and it's protective to the vascular system, keeps it younger and healthier. And so the sort of long-term risk is really opposite. There's a long-term benefit of hormone replacement therapy of decreasing heart attack and stroke and other complications like that. Again, we talked about osteoporosis earlier. And so, as far as long-term accumulative risk, there really, isn't a whole lot to worry about there. There's some acute risks of starting it, particularly side effects, and in the first couple of years. But after that, actually, it's beneficial for most women in the long term. There's only so much really long-term data out there, but that's the current thinking.
Okay. I have a couple specific questions that aren't again, I can't lump them together with anything else because they're pretty specific. So we have someone who's wanting to know if the treatment in perimenopause is the same for someone who also has PCOS.
Well, it all depends on how much the PCOS still affects them, really. So, when it comes to that condition, which for women that don't know what it is polycystic ovarian syndrome. And in polycystic ovarian syndrome, the normal hormone signaling that happens in the ovary doesn't always occur the way it's supposed to in women with PCOS. And so, every month, our lining of our uterus is supposed to kind of fluff up and get ready for a pregnancy. And then we have a hormonal cascade that then causes us to shed that lining if we don't become pregnant or have a fertilized egg. They don't have that normal cycle happening. And sometimes they can get an excess of hormones and a kind of a mismatch of hormones. And I used to describe it to patients as like the ovary and the uterus are just not communicating well. Like they're sending mixed messages to each other. Just a better way to explain it, without getting into the woods with the hormone levels and things. So with a woman with PCOS, they can have an excessive amount of masculine hormones in their system. They can have, more testosterone. They can have, masculinizing side effects from the disease process itself. And so in those patients, we might want to be careful with supplementing with something that can increase their testosterone levels if they're still actively seeing the symptoms that they were, experiencing with the active PCOS, like hair growth in unwanted areas, acne, male pattern hair loss, things like that. But if those symptoms have subsided as they're entering into midlife and they're no longer experiencing that, then we can still use a lot of the treatment modalities like the DHEA that we often prescribe for other patients. So it really is unique to each patient, whether or not, DHEA might be a good option for them or not. So if you have a history of PCOS, it's a discussion you should have with your doctor about what formulation of medications would be best for you.
We have two questions, interestingly, about how do you know, everybody knows when you're in perimenopause, but how do you know when you're done with menopause? So there's two questions on, how do you know when you're through officially?
Well, the textbook answer that we memorized in residency as OBGYNs was 12 months since your last period. Although the younger that you are, some people would say if you're less than age 50, you might need to go longer than that before you say you're officially done. Some might say it might need to be 2 years that you've gone without a cycle to say you're officially done, because in that perimenopausal time frame, things can get so erratic that you might have a day of spotting and not really consider that a period, but it may actually have been. So it's one of those things that it's a retrospective, meaning looking back and determining whether or not you're done. And so that's something that it's not like, Dr. Green mentioned earlier, we can't just pinpoint the day like, yes, today on October 12th, 2023, you are officially menopausal. Like we can't do that. It's really like looking at your total picture of health and looking back over the last year, talking about your menstrual pattern, talking about your symptoms. Some doctors will order a lab test called a follicle stimulating hormone, which will come back very elevated in a patient that might be menopausal, but that truthfully doesn't give us the pinpointed time either. So, it's something that, I can look at a lab level like that and say, yeah, you probably went through menopause or you're in menopause. It tells us a general idea, but we can't really pin it down to the day.
Well, imagine if you'd be really rich. Yeah. Right?
I'd be in Vegas.
I don't know. I don't know that it's that useful of a number, honestly, because the question, and if the question is when do you stop HRT, it's not necessarily the day you've gone 12 months without a period, because you may still need the hormone replacement. And so, again, I like to listen to the body. And so what I recommend is after you've been on HRT for a certain amount of time, usually a few years, and you think, well, gee, maybe I don't need this anymore, stop it. See how you feel. If you go, some time and you don't feel any different, and then there's no point continuing it. If you're miserable, let's start it back up. The only caveat I always say is that, don't do that like just before your kid's wedding or something like that. Do it at a relatively calm time in case, all of a sudden you're going to be miserable. So it's okay to do that. And I think it's a reasonable approach, and to do that, every year or two, once you've been on it for a certain amount of time, and see how you feel off of it.
Yeah, I don't recommend anybody going off their HRT in the middle of the summer either. I think the winter's a better time because, then at least environmentally, if you get really hot and you're dealing with hot flashes, you can just walk outside. And if you're living in a cold environment,
save on your heating bill, right?
Besides putting your head in the refrigerator, or, if you work in a restaurant, you can go in the walk-in freezer or something to help out.
Okay, good. I see, Dr. Kat, you answered a couple of the handwritten in questions that weren't in the chat. Thank you for that. We have a question about being on the birth control patch for perimenopause symptoms, and this person would like to know if they're on a birth control patch for perimenopause, can they still go on HRT?
Yes, you can. So because the medications work differently, your birth control is working to suppress ovulation to prevent pregnancy. And if you are still in your reproductive time frame, meaning really we recommend that if you still are having unprotected sex and you don't have another way to protect against pregnancy, that you stay on contraception. In general, we'd say that you can probably stop contraception at age 50 because your chances of spontaneous pregnancy are greatly reduced by the time we get to 50 years young. But you can start hormone therapy while you're still on birth control because the medications work differently. And so that's something that's safe to do. But you'll talk to your doctor about that as well.
Okay. We have a question from someone wanting to know, what is the benefit of having two types of estrogen in our compounded cream?
I'll let you take that one, Dr. Green. You're better at talking about that than me.
Okay, so we have estradiol and estriol. And those are two of the three hormones produced in the human body, and those are kind of the two main ones. Estradiol is the one that we hear most about. It's the one that sort of most of the sort of standard HRT, the bioidentical ones use estradiol. There's also something called Premarin, and there's estradiol, estradiol. So there's different estrogens, but the estradiol is probably has become much more common. It used to be everyone used Premarin. Premarin, by the way, stands for pregnant mare urine, and that's basically where they get it from. They have horses that keep pregnant, and they collect their urine, and they get the estrogens out of that horse urine, and they turn that into pill form, and that's what women take. And so you can imagine it's not really kind of the normal estrogens that women produce. But anyway, so we use estradiol and estriol. In our cream, we use a 50-50 mix. And I'll be honest with you, there isn't a lot of hard data that says that this is better than just estradiol. The concept is it's a little bit more physiologic. It mimics a little bit more what your body makes. It certainly isn't worse, and it may be better. My personal opinion is I don't think there's a huge advantage to it over just an estradiol by itself, which is why I don't have a problem switching people from the bias cream, which is the estradiol, estriol, to the estradiol only pill, the estradiol only patch. I think they're fairly equivalent. There's really no downside to it, and there are some people that think that it is more physiologic and it gives some added benefit. You get a broader range of the receptors you're hitting with the estriol than you do with the estradiol alone. But again, I don't know of any hard data that says that it's actually better. So again, straight shooter. The real reason that we use this is what our compounding pharmacists recommend. They think that it's better. They have way more experience with the art of compounding than I do, and so I take their advice and obviously do my due diligence and make sure that that the advice is sound. But that's really where this comes from.
Okay. We have a question regarding HRT and whether or not it will help someone regain vaginal moisture or their libido, to get the libido back.
Well, so supplementing with estrogen. What'd you say? So, did I ghost again?
Yeah, your disappearing act is in play.
I'm sorry about that. Okay. At least it makes you laugh, Dr. Green. So like we talked about estrogen being so beneficial for so many tissues in the body, adding estrogen in any form or shape will definitely help with the vaginal, tissues as well. Now, there is a way to make that happen a little faster, and that's by applying local vaginal estrogen to those tissues directly. Taking systemic HRT will help also, but the more rapid return of those tissues, making them more supple, more elastic, and restoring the quality of the epithelium and the tissues themselves will come from vaginal estrogen. In general, when our tissues are healthier, they have better blood flow, the tissues are thicker, we might just feel better overall. Also, that will make sex more comfortable. Lubrication will be improved. So overall, that may help with your libido and your desire for sex, just because your body part's going to work a little bit better when it's better estrogenized. The vagina is going to act better, be more accommodating. But there's so many other things that play into a woman's libido. I'll tell you that our biggest, most important sex organ as women is our brain. So much of it is very mental for us. And so there's so many other things that you have to work on, getting in the right headspace, doing other things to try to make sure that you're optimizing your sex drive and libido. And sometimes it comes down to making sure that we take the time in our relationships with other people to really put time and effort into, foreplay and the romance and the work that needs to be done on a relationship. You can't just say like, hey, you want to? Yeah, I want to. And then your body just can't respond that quickly. I tell patients, and sometimes their partners, especially if they have a male partner, will respond to this. You have to treat your body like it's a classic car. It's not like you would just go out there, take the cover off and turn it on and drive a marathon, drive a long drive. You got to take it off, rev the engine, maybe make sure you check the oil, wax it, maybe take it for a drive around the block, pamper it for it to act better. Our bodies are like that too. We need all those other things to make sure that our on switch, for sex is on. And if we have anything going on in our head or anything else, there's so many things that can block our libido and our sex drive as women. So there's a lot of other things that you have to work toward improving to improve libido. But yes, estrogen will help that indirectly. I mean, that was a long answer to a question, but good information to share anyway.
Okay. We have I think we've gone through the majority of these questions. We have an interesting question. I haven't heard this one asked, but maybe Dr. Green, you want to speak to this. Someone wants to know, do men go through a type of menopause or change in hormones?
So men do. It's different than what women. Men get a decrease in testosterone. It doesn't cause hot flushes and that kind of stuff, but it does cause fatigue. It can cause decreased libido. It can cause erectile dysfunction, and so it's not as pronounced as women. But there is some, and testosterone replacement therapy has become an important part for some men. As they go through this. So, there is a sort of a similar thing, not nearly as physiologically important or dramatic. The other thing is kind of interesting. So men have a much higher risk of heart attack and stroke than women do up until the age of menopause, and then women catch up. Not something you want, we all want equality, but not there. And the reason really is the lack of estrogen. And so men sort of don't go through that. Their risk just keeps gradually going up with their age. But women get this sort of big change, and men don't get that. And hormone replacement therapy helps to decrease that, so that you don't get that increased heart attack and stroke. That and that's one place, like I said, you don't want to catch up to men in. So the hormone changes are really sort of much more subtle and for men and don't have as much the kind of health ramifications necessarily that they do for women. So we have it lucky that way. Sorry gals, I didn't design it.
It's not a flaw in the design. I guess in our separate, and not in our chat, but in our question section, I see that there's a follow-up to the question about whether or not it was safe to have the patch and birth control at the same time.
I was just looking at that. So, and she put several different comments. So, at 51, going on a birth control patch would not be my first option for you. Just because I mentioned earlier, birth control hormones are synthetic hormones and they have a much higher risk of complications and those side effects like the clotting events. So generally after 50, I don't like to place any women on birth control of any kind. Hormone therapy would actually be the safer option because we can use lower doses to help with your symptoms. And unfortunately, many OBGYN physicians and providers out there will just gunshot and give birth control because that's what they have the most experience with. That's what they've been prescribing for decades. And if they don't have a comfort level with hormone therapy, that's not their go-to. But it's not the best for the symptoms that you're experiencing. So in this situation at 51, it might be time to reevaluate. And if you're, it might not be a good idea to be on that patch. If you were my patient, I would not have you on the patch. So just to share that.
Yeah, I had a OBGYN in the doctor's lounge tell me, oh yeah, I just put people on birth control pills and leave them on until they're 60. And I was like, that's a really lazy way. That's just sad, But he's like, yeah, it's just easier that way. It's like, well, it's not better though. It's like it's kind of a lazy way of doing things, and that's not great.
Wow, shocking. We have one more follow-up question. Shannon is asking, what would you say the most noticeable change for women is with DHEA and the cream?
What's the most noticeable change? As far as, I guess I don't know what she's asking.
I think it depends on, it depends on what you're coming in with,
Yeah, like what you're
saying. And they've got these miserable hot flashes and night sweats and it's just driving them crazy. And so we fix that and they're like, hallelujah. Other people have horrible brain fog. And so like, okay, I have a little hot flash, that's not a big deal, but this brain fog is like really affecting my work. And you fix that and it's hallelujah. So I think it really depends on the experience is so different for each woman that it depends on what you come in with. And so whatever your thing is, or things plural, that's really affecting your quality of life, when those get fixed, even though the other background stuff gets fixed, but when those ones get fixed, that's the most important one for you.
Okay, it sounds like she's saying she has all of those things you were mentioning and that it's helping her a lot, which is great. We love to hear that. I think we have answered just about everything here. I'm just doing a once over to make sure that we didn't miss anything crucial. I think this is it, everybody. I wanted to remind everyone, too, that you can message both of these lovely humans in the patient portal if they are your doctor, whomever your doctor is. I don't know if you can direct request message Dr. Kat or Dr. Green, but whomever your doctor is, please feel free to reach out to him or her with your questions throughout the course of your treatment. And if you haven't, join our Winona Women's group on Facebook. There's like 9,000 women in this group. So please join if you want community and camaraderie and hopefully some lightheartedness. Fingers crossed.
We should tell them about that lovely symptom tracker that you've shared before in other webinars too. So
let me put
if you are somebody who's in possibly perimenopause or maybe you've just started meds and you want a way to kind of objectively monitor your symptoms, we have a great symptom tracker at Winona that I've recommended for patients. Because I think that sometimes from day to day, we might not notice little subtle improvements, but then if you look at your frequency of symptoms like 2 weeks ago compared to today, and you keep track of things, it can help you to see how things are evolving in response to treatment, that kind of thing. But also it can help you to know if this is a good time to seek treatment too.
Yes.
Yeah, actually, I get patients, it's not uncommon that they don't think it's really helping, they stop it, and then they message me in a month or two, I'm miserable, can I go back on? And they didn't realize how much it was helping. And so, yeah, the symptom tracker can at least help you keep from making that mistake.
And we are hoping that the symptom tracker will be a little more interactive. I think this one it's great, but you have to print it out. So if you're a human that doesn't have a printer or likes to just, be on your phone, this might be a harder leap, but it's still a super helpful tool. I'm hoping we'll get an interactive PDF so you can just punch it into that document. But again, message us if you need help with anything. We're here for you across the board. All of us care how you feel. We want to answer your questions as best we can. So let us know. Oh, and just Dr. Kat and Dr. Green, in the poll that I made, 17% or 68% of people attending were Winona patients. 20% were thinking of joining, and 12% were not patients. So, and only about half of our people answered the poll. So the rest is a mystery. But for the people who answered, that's the data we have, which is pretty interesting. And let us know too, either in the women's group or, through customer service, if you like having these subject-based offerings. Tell us if you just prefer the regular live Q&A, which we are still having, everybody. This was just let's see how it goes. If people enjoy it, let us know. We love your feedback. But we will next month be back to our regularly scheduled programming, which is the three of us and or any other surprise people, who knows, a pet. We're not sure. Dr. Kat might disappear several times just for fun. And we'll see you guys next month, and it's going to be the following week after Thanksgiving. Usually it's the last the fourth Thursday of the month, but we bumped it a week so that it wouldn't fall on the week of Thanksgiving, so it'll be the actual last week of the month in November.
Yeah, that Thursday I won't be in any condition to do this.
Same thing goes for December. It will also be the last Thursday of the month for the holiday. So, and it's on our website as well. You can always go and check it out if you forget the dates, the times, and we will probably remind you many, many more times throughout Winona, however you receive your Winona news. So stay tuned, and thanks everybody again for being here, and to Dr. Green and Dr. Kat for your time and for all of the laughs and the good cheer. And hopefully this was of value to everybody, and we'll see you again soon.
Have a good night, everyone.
Bye.